So as I say, I'm Dr. Jonathan Fitzpatrick. I graduated from Glasgow University in 2015. As well as being a speaker for Invisalign, I'm also a clinical advisor for Aligner Consulting, and I help to run the Invisalign Go training courses. I'm currently undertaking postgrad diplomas in aesthetic and restorative dentistry, and also in clear aligner therapy. My practice is pretty much limited now to Invisalign and Ortho Restorative, and I completed about 150 Invisalign cases within the last year. So, what is the Invisalign Go Ortho Restorative journey? So, what I hope from today is to show you a predictable and repeatable workflow which will hopefully allow you to take your patients from here to here post alignment and bleaching to here post restorative. So this case was treated with 8 freehand composite veneers post alignment. Similarly, we should be able to go from a position here to here with simple alignment and edge bonding. And then we can also treat tooth wear cases as well with Invisalign Go. So we can take a patient from start position here and we can finish here. Again, purely additive dentistry with only alignment and composite bonding. So for me, this is true cutting edge, modern day, minimally invasive dentistry, and we need to think how the modern day dentist then fits in with this. So you need to think, for me, if you want to position yourself as a real leader in your field, at the cutting edge of developments within dentistry, really driving the latest techniques and treatments, and having the ability to provide your own patients with a truly world-class service. I mean, for me, the modern day minimally invasive cosmetic dentist encompasses personality, patient management skills, outstanding technical clinical skill, social media influence, and a driving passion to really go above and beyond for your patient. So the next question is to ask yourself, are you a modern day dentist? So at the moment, you really need to look and have a look at yourself and decide, are you currently intraoral scanning? Are you offering remote Zoom consultations? Are you using digital wax-ups and digital smile design processes? Are you adopting a true minimally invasive approach? And for that, teeth straightening needs to be at the heart of treatment planning. Then we move on to the modern day patient, or sometimes referred to as consumer modern day. So for me, patient perception and expectations have really changed over the last 10 or 15 years. The biggest patient demographic for Invisalign case submissions is 44% of patients are females aged 20 to 34. You need to think, what are we competing with in the lives of these patients? So these patients will compare your dentistry and practice to 5-star hotels, to high-end restaurants, to luxury retailers like Louis Vuitton or Chanel. What all of these industries really focus on and do a fantastic job of providing is a real emotional connection with any purchases that they offer. So it's about more than just the technology and the product of straightening teeth, it's about the service as well. So in my opinion, if you can marry the two, you can then provide a truly world-class service to your patients. So that means connecting with patients, delivering an unforgettable experience, take the patient on a journey to a better version of themselves. That philosophy will ensure you're far more successful than just delivering straight teeth. So what about Itero and how does Itero fit in with this? So intraoral scanning is really becoming the norm for providing cutting-edge dentistry and patient experience. We get improved accuracy, increased patient comfort, efficiency, increased case acceptance, as well as seamless digital workflows. Some of the features of the scanner which I particularly like and use on a daily basis: NIRI technology, which is near infrared imaging, so 850 nanometer light penetrates the tooth to provide the image which you see upper right of the screen. So enamel appears mostly transparent, and so that appears dark on the image. Dentine is scattering to NIRI, and so appears bright. So we end up with an end image at the top right where healthy enamel appears dark in colour interproximally, while proximal carious lesions appear brighter in colour. And you can see yourself there that the lesion in the mesial of that upper 7 is far more obvious on the NIRI image than it is on the intraoral camera image. So it's just a nice visual to be able to show patients and increase case acceptance. Next, the occlusal clearing tool is fantastic. So this displays all the occlusal contacts between upper and lower arches. For me, it helps identify any heavy contacts and it ensures we've got adequate occlusal clearance when we're doing tooth preparations for crowns, onlays and veneers. Invisalign Outcome Simulator is one of the single things that you can use to increase Invisalign patient numbers more than anything else for me. So it's a great visual tool. It allows the patients to see how their own teeth will look after alignment. You can make real-time adjustments while the patient's in the chair to customise the simulation. And for me, it's a key part of every new patient consultation to increase both confidence and case acceptance. So why do I use Invisalign Go for almost all, if not all, of my cosmetic cases? So alignment of the teeth allows for minimisation of tooth preparation, increases predictability of the restorative material we're then going to use by improving the occlusion, improving the envelope of function, overjet and overbite. It ensures longer lasting restorations. We have prevention of tooth wear, and you also get an improvement in the final aesthetic outcomes, such as levelling of gingival margins for high smile line cases, or have an even thickness of restorative material for composite or ceramic. So a few tips from my point of view on increasing case numbers. So as well as the Itero scanner being a key part of every new patient consultation, I actually scan every patient also at routine recalls, which is great for monitoring things like tooth wear or for teeth drifting. But it's a great tool. A lot of patients won't have seen this occlusal view of their upper and lower teeth in their life, and so they won't have an idea about how crowded or misaligned their teeth are. It allows you to discuss the benefits of alignment. You can run the Invisalign Outcome Simulator. We can then use the Occlusal Clearance tool as discussed to show areas of tooth wear or heavy contacts, and we can then also discuss crowding and how this can worsen over time, because I think a lot of patients don't appreciate that crowding is not a static position, so teeth will continue to crowd throughout their life, and sometimes early intervention is a more inexpensive and less destructive option for a patient at an earlier stage. Developing your mindset is another point I've put in here, because for me the technology is fantastic, but you need to go into Invisalign treatment with a really clear mindset of what you want to achieve. So in my opinion, the Invisalign providers who provide little to no case numbers generally look for excuses about why that's the case. So they will say they're in the wrong practice, they don't have enough experience, they don't have the right patient cohort, which is just not the case at all. I've gone from where I was a couple of years ago, one Invisalign case a month if I was lucky, so now we're doing on average at the moment 15 plus per month. I'm in the same practice, we've got the same staff. It's just a bit of a change of mindset to stop looking for excuses and start looking for reasons about why you can really increase numbers. So let's have a look at a case. So we're going to work through a case example, which is Invisalign Go with digitally guided composite veneers. So this case was written up for Cold Clean for Scottish Dental Magazine. It's a really easy workflow. The restorative part with the guided composite veneers means that you don't need any hands-on composite freehand skills to get a good result, and it's also a really predictable workflow, as we'll discuss. So pre-op, patient came in unhappy with upper and lower crowding. We also had some buccal abrasion cavities present. There was also a restricted envelope of function because the upper central incisors were mesially rotated, and you can see the incisal wear on the mesial aspect of those, as those were the first point of contact and protrusive movements. So, treatment plan. We used Invisalign Go to align the teeth, improve the envelope of function, overjet and anterior guidance. We did some teeth whitening. What we then did was a digital wax up and trial smile, which we will discuss later. We provided digitally guided composite veneers for the upper 2 to 2, and then we took care of the retention and maintenance. So this is a look at the Clincher Planning for this case. So before on the left and after on the right. So as you can see, we've got better alignment. We've used some IPR on the lower, which is interproximal reduction, where we make tiny little spaces of 0.2 of a millimetre between the lower teeth, which allowed me to pull those back slightly and improve the overjet and make space for my restorative material. A bit of a few kind of tips really for me on Clincher Planning and set up for these ortho restorative cases. In most cases, you want to try and finish with 2 to 4 millimetres of overjet to ensure adequate space for the restorative material you're going to use. You want to aim to try and finish with about a 30% overbite, which is a fairly safe overbite amount. A class 1 canine relationship to finish is always a good option because that will ensure good canine guidance and space to restore the upper 2 to 2. And after alignment, but before providing any restorative at the front of the mouth, I would always check static and dynamic occlusion before restoring to make sure that you have the adequate space. So we got the patient to here, so this was after alignment. For a lot of these cases, we discussed that sometimes things can look a little bit worse before they look better, because if you've got areas which have worn flat with the teeth in the wrong position, aligning the teeth then brings the incisal edges to a position where they're maybe not the most aesthetic, but it highlights for the patient how much tooth wear that he's had over a long period of time. If we look a bit closer, as you can see, marked incisal wear and buccal abrasion cavities affecting the upper anteriors. So the planning from here after alignment, we sent some photos and intraoral scans from the Itero to the lab. We asked for a digital wax up for additive composite veneers for the upper 2 to 2. So at the top you can see the pre-op model. Middle photo is the design that the lab have done for us, and then we make a clear stent over this wax up, which we use, first of all, we fill with temporary crown material and put it in the patient's mouth, let it set and remove it, and that then lets the patient trial the aesthetics. We can have a look at the occlusion statically and dynamically. We can approve shapes, but from here we can also make some changes. So if we need to shorten things, lengthen things, make things more square, we can really customise things before providing the final restorative. So as I say, digital wax-ups give you predictable, reliable, reproducible results. You get better informed consent and treatment uptake. There's a real ability to modify and change aspects of the wax-up really quickly and inexpensively. A lot of time my lab will send me the digital files of the wax-up before they print it, so that I can pre-approve it. I'll have a look and I'll make any changes that I want to make before it's even printed. But even after printing, it's really easy and inexpensive to modify and change things. And it really lets you accurately reproduce the result from a trial smile, from a consent point of view, into the final result. So, what we did, every second tooth is covered with PTFE tape and isolated. We etch and bond the uncovered teeth. We then fill the stent with composite for the teeth that are uncovered, and we fully seat, tack cure the composite for 2 to 3 seconds. Then I'll remove the stent, and at that point the composite's still unset, so I'll just go around the margins with a scalpel to remove any excess. Then we fully cure, and then we repeat the process for the other teeth which were covered with the PTFE. And then that takes us to a final position where this is the final smile. So easy, reproducible, the aesthetics are the exact same as what the trial smile were. Patient's already consented to it. I know that's not going to chip or break nearly as much as it would have pre-alignment because I've checked the occlusion statically and dynamically. And that's just for me a really easy, reliable, repeatable workflow that anyone can provide, so you don't really need any real skills in doing composite to provide that sort of cases. So that brings us to the end. So thank you very much to everyone for listening to my presentation.